Greetings, my dear students. With you, Mona Talab, Associate Professor of Clinical Hematology. My topic for today is hematologic emergencies. My agenda for today will start by intravascular hemolysis, thrombotic microangiopathy, disseminated intravascular coagulation, and lastly, febrile neutropenia. First, hemolytic anemia. Hemolysis is the destruction or removal of red blood cells from the circulation before their normal lifespan of 120 days. While hemolysis can be a lifelong asymptomatic condition, it most often presents as anemia when erythrocytosis cannot match the pace of red cell destruction. Hemolytic anemias classified into hereditary hemolytic anemias and acquired hemolytic anemias. Hereditary hemolytic anemias consist of defect in the membrane in the form of hereditary elliptocytosis, hereditary spherocytosis, metabolic defect in the form of G6PD, pyruvate kinase deficiency, and hemoglobinopathies, for example, thalassemia and sickle cell anemia. Regarding acquired hemolytic anemia, immune hemolytic anemias includes autoimmune hemolytic anemias with its subtypes warm and cold type hemolytic anemia, alloimmune hemolytic anemia, for example, hemolytic transfusion reactions, hemolytic disease of the newborn, allograft, especially stem cell transplantation. We have drug-induced hemolytic anemia. We have also a type of hemolytic acquired anemia in the form of red cell fragmentation syndromes, March hemoglobinuria, infection, for example, malaria and clostridia, chemical and physical agents, secondary to liver and renal disease, and lastly, paroxysmal nocturnal hemoglobinuria. There are two mechanisms of hemolysis. Intravascular hemolysis is the destruction of red blood cells in the circulation with the release of cell contents into the plasma. Mechanical trauma from damaged endothelium, complement fixation and activation on the cell surface, and infectious agents may cause direct membrane degradation and cell destruction. The more common extravascular hemolysis is the removal and destruction of red blood cells with membrane alteration by macrophage of the spleen and the liver. The diagnosis of extravascular hemolysis is established by reticulocytosis, increase in the unconjugated bilirubin, increase in the lactate dehydrogenase, decreased haptoglobin level, and peripheral blood smear finding. This is the pathobiology of intravascular hemolysis. During intravascular hemolysis, hemoglobin is released into the plasma, where it's normally cleared by the hemoglobin scavengers, haptoglobin, CD163, and hemopexin. Haptoglobin hemoglobin complexes bind to CD163 on the surface of the macrophage and the monocytes, initiating endocytosis and degradation of the complex. Hemoglobin also releases ferric heme on oxidation, which is bound by hemopexin and degraded by the hepatocyte in the liver. With excessive hemolysis, it will saturate and deplete these hemoglobin removal systems and lead to build-up of hemoglobin and heme in the plasma. Plasma hemoglobin and heme mediate direct pro-inflammatory, proliferative, and pro-oxidant effect on the vessel endothelial cells. On the other hand, we have nitric oxide. Nitric oxide is normally generated from L-arginine in the vessel endothelial cells by enzyme nitric oxide synthase. Nitric oxide maintains smooth muscle relaxation and inhibit platelet activation and aggregation, thereby regulating vessel tone and promoting organ system homeostasis. During intravascular hemolysis, nitric oxide availability can be severely limited by its reaction with oxyhemoglobin, which is considered to be nitric oxide scavenging. and by breakdown of the substrate for nitric oxide synthesis L-arginine by red cell enzyme arginase. Nitric oxide depletion results in decreased activation of guanylate cyclase, an enzyme required for generation of cyclic GMP. Decreased cyclic GMP levels disrupt regulation of smooth muscle tone, resulting in dystonias including systemic and pulmonary hypertension, erectile dysfunction, dysphagia, and abdominal pain. Decreased cyclic GMP level through depletion of nitric oxide can also lead to platelet activation and aggregation, promoting clot formation. Hemoglobinuria is one of the most prominent clinical signs of excessive intravascular hemolysis. Plasma hemoglobin is normally filtered through the glomerulus and actively reabsorbed in the proximal tubular cells, where it is catabolized with the release of iron in the form of hemosiderin. When the kidney's reabsorption capacity is exceeded, clinically significant hemoglobinuria occurs. Acute renal failure may occur during severe episodes of hemoglobinuria. Hemolytic conditions with substantial intravascular hemolysis include paroxysmal nocturnal hemoglobinuria, sickle cell disease, thalassemias, hereditary spherocytosis and stomatocytosis, microangiopathy, pyruvate kinase deficiency, and EPO mismatched transfusion reaction. There are two mechanisms of hemolysis. Intravascular hemolysis is the destruction of red blood cells in the circulation with the release of cell contents into the plasma. Mechanical trauma from damaged endothelium, complement fixation and activation on the cell surface, and infectious agents may cause direct membrane degradation and cell destruction. The more common extravascular hemolysis is the removal and destruction of red blood cells with membrane alteration by macrophage of the spleen and the liver. The diagnosis of extravascular hemolysis is established by the pathophysiology of thrombotic thrombocytopenic purpura. Multimeric von Willebrand factor adheres to the endothelial cells or to the connective tissue exposed in the vessel wall. Platelet adheres to the von Willebrand factor through platelet membrane glycoprotein 1b. In circulation, von Willebrand factor is unfolded by shear stress and cleaved by ADAM-TS13, limiting thrombus growth. In the absence of ADAM-TS13, uncleaved ultra-large von Willebrand factor multimers bind to platelets in high shear environments, forming inappropriate microthrombi that cause microvascular occlusion and microangiopathic hemolytic anemia, which results in organ ischemia. In ADAM-TS13 is severe deficiency, accumulation of von Willebrand factor platelet aggregation continues, eventually causing microvascular thrombosis and TTP. We have two types of thrombotic thrombocytopenic purpura. Congenital thrombotic thrombocytopenic purpura is a rare disorder of homozygous or compound heterozygous gene mutation leading to inherent deficiency of ADAMTS13. Acquired TTP is due to deficiency of vulval branch factor cleaving serine metalloprotease called ADAMTS13. Anti-ADAMTS13 antibodies, mainly IgG, contribute to the pathogenesis of acquired TTP. This autoimmune process may be a result of first, neutralizing antibody that inhibits ADAMTS13 proteolytic activity, or non-neutralizing antibodies that interfere with important ADAMTS13 binding partners or that enhance clearance of ADAMTS13. The circulating red blood cells that are forced through these occluded vessels are deformed and fragmented, which produce the characteristic histiocytes. These fragmented red cells are removed by reticuloendothelial system, resulting in hemolytic anemia. Because platelets are consumed in the process of vascular injury, most patients also develop some degree of thrombocytopenia. Regarding renal abnormalities in patients with TTP, proteinuria and hematuria are common in TTP. In contrast, acute renal failure with marked azotemia, fluid overload, hypertension, and need for dialysis is much less frequent. The renal manifestations of hematuria, proteinuria, and mild impairment of the clearance function in TTP are consistent with focal and segmental distribution of microthrombi most commonly observed. Pathological examination revealed microthrombi typically affect one or a few segments of the glomeruli. Although the extent of the glomerular thrombi varies widely among the patients, widespread glomerular or cortical necrosis and fibrosis are uncommon in TTP. Neurological abnormalities were present in 66% of patients. 35% of patients have major abnormalities in the form of coma, stroke, seizure, or focal abnormalities. 31 patients had only minor symptoms such as confusion or headache, which may or may not have represented the neurological abnormalities. And 34% of patients had no neurological abnormalities. New neurological manifestations may occur during the course of treatment. TTP is diagnosed through combination of history, clinical examination of the patient, and blood film finding. ADAMTS13 activity assay assists in confirming the diagnosis. In TTP, ADAMTS13 activity is typically 5% of normal. Additional inhibitor assays or detection of anti-ADAMTS13 antibody are useful in distinguishing between inherited and acquired forms of TTP. These assays are also particularly useful for monitoring patient response to treatment. Regarding treatment of TTP, we first start by plasma exchange of one plasma volume once daily with corticosteroid in the form of prednisone 1 mg per kg per day, with continuous daily monitoring by platelet count and LDH level. We should continue the plasma exchange until platelet count more than or equal 150,000 for 2 consecutive days, with clinical improvement and no new neurological manifestation and near or near normal LDH level. At that time, we can stop the plasma exchange with close monitoring of platelet count, and after 1 to 2 weeks, if there is a clinical improvement, we could taper the corticosteroid. In the refractory patients to a plasma exchange, we can increase the plasma exchange to 1.5 plasma volume we can increase the steroid dose into high dose corticosteroid, and we can add rituximab anti-CD20 375 mg per square meter weekly for 4 weeks. And in refractory patient to these mentioned lines, we can add immunosuppressive drug in the form of cyclophosphamide, vincristine, or cyclosporin. Disseminated intravascular coagulation. Disseminated intravascular coagulation, DIC, is a clinical pathological syndrome which complicates a range of illness. It's characterized by systemic activation of pathways leading to and regulating coagulation, which can result in generation of fibrin clots that may cause organ failure with concomitant consumption of the platelets and coagulation factor that may result in clinical bleeding. Association and pathogenesis of DIC. DIC never occurs in isolation, and recognition that a patient has a clinical disorder which may result in the development of DIC is the key to appropriate investigation and management. DIC may arise in patients with a wide spectrum of disorders, including sepsis, malignancy, trauma, liver disease, and vascular abnormalities. It's also seen when pregnancy is complicated by a placental abruption or amniotic fluid embolism, and may complicate poisoning and major transfusion reactions. All of these conditions share the ability to induce systemic activation of coagulation, either by activating cytokines as part of systemic inflammatory response, or by causing the release of or exposure to procoagulant substances. Hemolytic anemias classified into hereditary hemolytic anemias and acquired hemolytic anemias. Hereditary hemolytic anemias consist of defect in the membrane in the form of hereditary elliptocytosis, hereditary spherocytosis, metabolic defect in the form of G6PD, pyruvate kinase deficiency, and hemoglobinopathies, for example, thalassemia and sickle cell anemia. Regarding acquired hemolytic anemia, immune hemolytic anemias includes autoimmune hemolytic anemias with its subtypes warm and cold type hemolytic anemia, alloimmune hemolytic anemia, for example, hemolytic transfusion reactions, hemolytic disease of the newborn, allograft, especially stem cell transplantation. We have drug-induced hemolytic anemia. We have also a type of hemolytic acquired anemia. Thrombin is generated predominantly by extrinsic pathway involving tissue factor and activated factor 7. There is decrease in the level of all major physiological anticoagulant like antithrombin 3, protein C, and tissue factor pathway inhibitor. Antithrombin 3, which is the most potent thrombin inhibitor, is markedly reduced due to consumption, impaired synthesis, and degradation by elastase released from activated neutrophils. The decrease in the total protein C level is caused by consumption and impaired synthesis. The fibrinolytic system is suppressed at the time of maximal activation of coagulation. This inhibition is caused by sustained increase in level of plasminogen activator inhibitor 1. Though secondary fibrinolysis occur in response to fibrin formation, its activity is too low to counteract systemic deposition of fibrin. There is no gold standard for diagnosis, but 3 respective national guidelines: the International Society of Thrombosis and Hemostasis, Japanese Ministry Health, Labor and Welfare, and Japanese Association for Acute Medicine, place an emphasis on simple algorithms and scoring systems based on readily available laboratory tests. As you see, this table presents the scoring systems for DIC that are most evidence-based with respect to pathophysiological outcomes such as organ failure and mortality. This is another scoring algorithm for diagnosis of DIC. The scoring system is only appropriate in patients with an underlying disorder that can be associated with DIC. A score of more than or equal 5 points is compatible with DIC. If score less than 5, consider repeating after 1 to 2 days. The pathophysiology of thrombotic thrombocytopenic purpura. Multimeric von Willebrand factor adheres to the endothelial cells or to the connective tissue exposed in the vessel wall. Platelet adheres to the von Willebrand factor through platelet membrane glycoprotein 1b. In circulation, von Willebrand factor is unfolded by shear stress and cleaved by Adam TS30. Neutropenic fever. Neutropenic fever or febrile neutropenia defined as single temperature of more than 38.3 degrees centigrade orally or more than or equal to 38 degrees centigrade over 1 hour with neutrophil count less than 500 per cubic millimeter or 1000 per cubic millimeter and predicted decline to be less than or 500 per cubic millimeter over the next 48 hours. The scope of the problem of febrile neutropenia is the absence of the granulocyte. The disruption of the integumentary, mucosal, and mucociliary barriers and inherent microbial flora shifts accompany severe illness, and antimicrobial usage predispose the neutropenic patients to infection. The pathogens responsible for the initial infections early in the course of fever and neutropenia are primary bacteria. Coagulase negative staphylococci, Staphylococcus aureus, very dense group, streptococci, and enterococci are now the major gram-positive pathogens. Escherichia coli, Klebsiella species, and Pseudomonas are the most common gram-negative pathogens causing initial fever. Herpes simplex virus, respiratory syncytial virus, parainfluenza, and influenza A and B are also occasional initial pathogens. Infections due to Candida may occur later in the course of neutropenia, particularly as a consequence of gastrointestinal mucositis. The signs and symptoms of infection are often absent or muted in the presence of neutropenia, but fever remains an early although non-specific sign. The overall infection risk in neutropenic patients are subclassified into low, intermediate, and high based on disease category, type of therapy, and anticipated neutropenia. Initial risk assessment for febrile neutropenic patients. High risk patients who have any factor listed below should be admitted to hospital with IV antibiotic therapy. Low risk patients who have none of the above factors and most of the following should either admitted to hospital with IV therapy or sequential IV oral therapy or just oral antibiotic therapy. Consider ambulatory clinic or home treatment for selected low-risk patients with adequate outpatient infrastructure established. This is mass risk score model. Patients who have less than 21 risk scoring system classified as high risk patients, and patients who have 21 or more risk factors should be classified as low risk patients. The recommendation approaches for febrile neutropenia. The selection of initial therapy should take into consideration the following factors: the most common potentially infectious organism, the potential sites of infection, antimicrobial susceptibility, the patient's infection risk assessment, the importance of broad spectrum antibacterial activity, Evidence of clinical instability, for example, hypotension, patient's medication allergy, organ dysfunction, and previous antibiotic therapy. First approach, intravenous monotherapy. For example, carbapenem, imipenem, celestin in a dose 500 mg every 6 hours. Meropenem or meronem 1 to 2 gram every 8 hours or 500 mg IV every 6 hours. Extended spectrum anti-pseudomonal cephalosporin, ceftazidime or cefepime in a dose of 2 gram every 8 hours. Piperacillin tazobactam is also an effective monotherapy in a dose of 4.5 gram every 6 hours. Second approach is dual intravenous monotherapy. The second approach is intravenous dual therapy with an aminoglycoside plus an anti-pseudomonal penicillin, gentamicin, topramicin, or amikane. Aminoglycoside plus extended spectrum anti-pseudomonal cephalosporin, or ciprofloxacin plus anti-pseudomonal penicillin 500 to 750 mg per oral every 12 hours or 400 mg IV every 12 hours. Aztreonam plus clindamycin or vancomycin added to febrile neutropenic patients, especially penicillin allergic patients. And lastly, ceftriaxone 5 gram every 24 hours with ciprofloxacin 500 mg IV every 12 hours. Results of daily monitoring. Patients who are clinically stable or improving and fever decreasing with neutrophil count more than or equal to 500 per cubic millimeter, I can discontinue the therapy. And if the neutrophil count less than 500 per cubic millimeter, I can either discontinue the therapy or de-escalate to prophylaxis antibiotic therapy or continue current regimen until neutropenia resolves. On the other hand, if the fever persists more than or equal to 4 days, I can consider the antifungal and antiviral therapy. And the duration of therapy depends on the clinical course, neutropenia recovery, toxicity, and opinion of infectious disease consultant. Non-responding patient or clinically worsening patient, persistent febrile neutropenia, persistent bacteremia, I should broaden the coverage based on the clinical and microbiologic data to include other organisms not covered by initial empiric regimen. Consider imaging studies and further microbiological testing, including X-ray and CT scan. Consider adding granulocyte colony stimulating factor or granulocyte macrophage colony stimulating factor. I should either admit it to hospital with IV therapy or sequential IV oral therapy or just oral antibiotic therapy. Consider ambulatory clinic or home treatment for selected low-risk patients with adequate